Hi, for those of you who don't know me, I'm Nicholson, and I am not the only author on this project. My co-author, Becky Eisenberg, right here in the front row, but she has not seen this presentation yet, so if I say anything ridiculously stupid, please attribute it only to me. So this is a young project, it's just a few months old. We're very interested in your comments and feedback. It's kind of an area that's of interest to both of us, but we're seeing as we go forward. So what am I talking about when I say demand-side innovation in healthcare? I'm going to start by trying to situate the project and talk about what we're thinking about, and then I'll go through it in a slightly more traditional way. So we think about innovation and inventorship and things like that, and so we talk about innovators. So this is Salk, who invested in, wait, no, it's not Salk.
Whoever.
Yes. So we think about the original bonus points to anybody who can name them. All right, well, anyway, these days we're not really talking about individual guys sitting in labs thinking up drugs. We're thinking about drug companies in the sandbox that Becky and I tend to play with. And what we care about with drug companies is that they invent drugs and that they make drugs so that people can take them. But what we really care about more is that they come up with a lot of information. So Becky wrote some of the very early stuff on this, but a lot of what we want from drug developers is that they give us all this costly information about what's safe and what's effective and why their drug works and how. And the problem, of course, is that all of this costs lots of money to develop. And so in this area of innovation law, we spend a bunch of time thinking about how do we get money to drug companies to recoup that investment. So we've got the basic people pay you for the drugs and then they have money. And if we don't think that's enough, then we add in IP and patents and regulatory exclusivity so people pay you more because you can raise the prices and now they have more money. Or we just give them directly grants and prizes and they have more money, or we reduce their tax expenditures and they have more money and so they develop all this stuff. And in particular, they develop this information we want. But the problem is that we want a bunch of information about how drugs or other medical technologies or other things work. And no matter how much money you kind of shove at these people, there are certain types of information they just don't want to come up with that we want. So the clearest example of this is drug toxicity. So Merck sold Vioxx for a long time, and they made billions of dollars every year on Vioxx. And it turns out that Vioxx killed a lot of people because it caused a lot of heart problems, and they kind of seemed like they knew that for a while. But that's not the kind of information they really want to share, because they're making billions of dollars, and that's great. Now, there are some ways that we try to deal with this directly. We have FDA requirements that you have to show safety and efficacy through clinical testing. There's worries about torts and reputational costs and yada yada, but we want that information, and fundamentally the incentives are challenging for them to develop that kind of information. So what this project is saying, hey, what's up here? Are there other ways and other sources of getting information that comes kind of directly from the experience of patients and of users and the demand side of things, rather than the supply side of things, rather than people making the drugs, people using and prescribing the drugs? Can we get at that information? And the actors that we're particularly interested in are the payers. And so when I say payers, I mean, roughly speaking, the people who pay for healthcare. So those are insurers, both private, like Aetna, United Health, public, like Medicare and Medicaid, or integrated systems like Kaiser Permanente that both provide care and pay for it. All right, so that's all I've got for fancy slides. Now I'll move on to boring slides with small amounts of text on them and go through what we think is actually maybe going on in this area. So first I want to talk about what kind of innovation we're talking about. Second, why payers, what do they have to do with it. And then third, the bulk of this will be kind of the hurdles and policy initiatives that we have in this area. And if you missed Mike Mattioli's talk last section, you should definitely look at his paper. If you find this at all interesting, you should definitely look at what he's doing, because I'm very excited to do the same thing. Well, look at his stuff, not do the same. Likewise. All right, so what kind of innovation are we talking about here? Well, the first is drug toxicity. Obviously, if insurers have patients that are dying from drugs, you don't want to be prescribing those drugs to patients. We've actually got really great examples of this. So Kaiser Permanente was involved in a huge study that helped demonstrate that Vioxx was in fact killing a lot of people. So insurers are interested in this kind of information. Drug companies have some challenges in developing it. Comparative and cost effectiveness research. What I mean by this is comparative effectiveness is saying we have two interventions, which one of them tends to do a better job in helping people. cost effectiveness throws money into the mix. How much money do we buy, or how much health do we buy for a particular amount of money? The third type is personalized medicine. So Plavix, for instance, is a drug that's used to help reduce the risk of atherosclerotic heart failure, but for about a quarter of patients it doesn't work. They just have the wrong genetic makeup, it doesn't help them at all. So if you're a drug company, you might say, well, yeah, that's a piece of information that might be useful for me to know because I could target it better, but the flip side of that is saying I've just lost a quarter of my market share. So that's not to say that drug companies can't kind of deal with this sort of thing. If they have a way to increase prices for more effective drugs, then they can do that. But particularly for drugs that are already kind of out on the market, it may be harder for them to do that sort of price changing, and so they're less interested in developing this type of information. All right, so this is information we might want. Why do we think that payers might be good places to look for it? So part of it is the data. Health payers have really interesting access to tons of data across broad spectrums of people. So administrative claims data is the kind of stuff they have automatically, which is when patients go to the hospital, what they're treated for, what procedures are done, what drugs they take, all that kind of stuff. They have that, and then increasingly they're having access to clinical data themselves from the doctors. And of course, when we're talking about integrated payers like Kaiser Permanente, then they all have that already. So they've got a big population, a lot of health data for the population, and in particular, this is data that the drug companies tend not to have. The other point, and I think this is really, for me, a lot of the key to the project, is the incentives that payers face are substantially different from the incentives that drug companies face. So, drug companies in general, or producers in general, have an incentive to produce stuff and have you buy it, and ideally have that stuff be expensive, or as expensive as profit maximizing goes, because they want you to spend more, because when you spend more, they get more money. Payers have the opposite incentive. They have incentives for frugality. They would like to spend much less because the money coming in remains relatively constant, and the money that they put out, they'd like to decrease that. Now, there are, of course, massive caveats on this in terms of things like decreased market competition, in terms of things like the Affordable Care Act limits. I'm not going to talk about the details of that, but if you're curious, I'm happy to talk about them in the Q&A. The other thing I want to emphasize is that we're not arguing that these incentives are perfect incentives, that we have this wildly flawed set of information about drugs, and suddenly if we bring in health payers, that we'll get the right information. There are certainly problems that happen when you have health insurers who are determining what payments people should and shouldn't get, because they have that incentive towards frugality, and we may well worry that they don't buy enough health for the money. Our argument instead is not that these are perfect, but that if we want a balanced view of all the information, or the most useful information about medical treatments, it's a good idea to have people from multiple different sides of the equation, and payers can provide a counterbalancing viewpoint to the information we get so far from the producers of medical technology. All right, so I'm going to talk about hurdles, but first I want to take a step back, or a step to the side. Let's talk about intellectual property, because I'm about to tell you, here are ways that this is difficult. And the answer to that, since we're stating an Ipsc, is we'll throw IP at it, because that will solve the problem. If it's difficult, just give people more money and then they'll do it. But IP, for a couple of reasons, doesn't work particularly well for this type of information. The first is that on the kind of Said-Kapczynski excludability continuum, this type of information is really hard to appropriate. It's tough to appropriate the information that a drug is toxic and kills a lot of people for various reasons, many of which I hope are obvious, like ethics. It's also tough to internalize the cost effectiveness. This is slightly better than that for the money. So these are types of information you really can't patent it. Even the diagnostic things obviously are tough to bring out for patenting, and keeping things secret is incredibly hard when what you have to do is tell all the doctors, hey, do this and save lives, or do this and save money. That really doesn't work well with the secrecy view. So IP makes it really tough to appropriate this type of innovation. That's not to say IP doesn't do anything. In particular, a big effect of IP is, well, when you have patents on drugs, those drugs are more expensive, and hospitals and payers don't necessarily, or payers, not hospitals, don't necessarily want to use those more expensive drugs, so they have an incentive in the opposite direction to try to find research that says, hey, this generic drug is just as effective as this more costly patented drug. So IP is here, but IP isn't really the solution. All right, so on to hurdles and what is being done, which we think is kind of interesting and varied. The first big hurdle I want to talk about is HIPAA and privacy. This is the big legal hurdle here. Of course, many of you, if you are a privacy person, you might say, hurdle? No, HIPAA's awesome, it's fantastic, it protects our privacy, that's wonderful, please don't touch my HIPAA. We're just taking a view here on innovation and not dealing with the privacy impacts, but of course there is a balancing act to be done, which we are happy to talk about in parallel work. So what HIPAA basically does, it refers to any protected health information, which is individually identifiable information that is generated by, disclosed by, or disclosed to a provider or an insurer. So basically any kind of health information that's individually identifiable that is interesting, and there are lots of other stuff out there, counts as HIPAA, and what HIPAA basically says is, hey, you cannot use this or disclose this unless you fit into one of several enumerated exemptions, and even if you do fit into one of those exemptions, you have to use the minimum amount of information necessary. One way to get around this is anonymization, but as Mike pointed out in the last talk, if you do that, you lose a ton of the stuff that is interesting about the data if you strip off all the identifying information. Important thing of those exemptions I mentioned, research is not one of them. So you might say, hey, that would be handy if we could just say, we'll use this, it fits in one of the categories, but in fact it specifically doesn't, and there is a specific line in the statute that says if it is for the purpose of generalizable knowledge, it does not count as an exemption under HIPAA. So if you talk to health IT people, this is where they start tearing their hair out. Trying to do things with HIPAA without anonymizing things is very, very difficult. So policy interventions that might help a little bit. The HITECH Act, I'm putting it here in brackets because while the HITECH Act of 2007 does talk about HIPAA and clarifies things around the edges, it's kind of like snipping off a few branches of a giant bush that's in the middle of the road, and it doesn't make, I think, a huge positive difference in terms of the HIPAA hurdles. On a potentially brighter note, the 21st Century Cares Act actually has that odd thing, a clean, elegant statutory switch that actually entirely removes a project, which is just to say, hey, HHS, please clarify or revise, amusingly not clear which, that research is an exemption under HIPAA, and so that problem that I talked about just kind of goes away. So this would be great if it happens. Frankly, who knows what's happening with the 21st Century Cares Act or with the Senate, but hopefully in a couple months this slide will just vanish. The other set of hurdles that I think are kind of more interesting and more varied are the technical hurdles to actually getting this done, and this is the kind of, this is the meat of the innovation problem. How do we actually deal with making this innovation happen? And so on the data side, which is how do you get all this data to work and how do you get it together across different systems and different providers, the first problem we talk about is aggregation, which is bringing data together. So patients see lots of doctors over time and at any given time, and over time they also shift between different providers because they change jobs, or different payers because they change jobs, they move out of state, things like that. So bringing that data together is a major challenge. Making that more complicated is the issue of interoperability. Everybody stores their data in different formats, people code different things. One doctor may say the patient is overweight, and one doctor may say the patient has a BMI of 37, and those two types of things are things you would like to be able to correlate and link together in a single patient record, but it's hard to do that. And the third issue big is just data quality. So there's human error, there's sloppiness and all of that, but underlying it is the fact that a lot of this data is coded for the purpose of payment and reimbursement, and not necessarily for the purpose of actually documenting exactly what's going on in a patient's health. So if what you're interested in is that sort of health research, you might worry about systematic biases in the data. So on to some interventions that are going on, which aren't kind of the standard innovation policy interventions. Electronic health records. So we don't think about, well, many of us don't think about electronic health records at all, but for those of us that do, I did not think about this relatively recently as a kind of strong government initiative. It just seems like the sort of obvious thing where, of course, if everybody else in the world is starting to use electronic records, hospitals are too. It turns out that's really not the way it is or was. And the reason that we have many more EHRs than we used to in the past, about 70% adoption now, is basically because in the ARRA, the American Recovery and Reinvestment Act, $30 billion was put towards making incentives for hospitals to implement EHRs. So this is an area where strong government investment is trying to help create the infrastructure, not just for this, but which helps enable this type of innovation. The Office of National Coordinator, which is the office that developed these EHRs, also has an initiative trying to help solve the interoperability problem. In November 2014, they put out a roadmap on interoperability, basically analogizing to APIs and saying that people should have similar ways of being able to integrate their data together between different sources. The government, as a third type of way that we've got federal investment in here, is creating big research infrastructure which helps solve some of these technical problems. So Sentinel is an FDA initiative to measure post-approval drug safety. It's supposed to have records on 100 million people within the next decade or so. And that type of distributed data architecture, again, not directly saying private innovators, here's how we're driving you, but helping to create the infrastructure and the tools necessary for that innovation to happen. And finally, a few more ways that the government directly is doing this type of innovation a little bit on its own. So the CORE, the Patient-Centered Outcome Research Institute, is the Affordable Care Act's way of saying we'd like to do a little bit of cost-effectiveness research on our own. So what we're seeing here, I think, is a really interesting pattern, which is the government, or the federal government in particular, recognizing that this is an area of innovation that needs to happen, and that faces real technical and legal challenges, and putting into play a number of different tools than the ones we typically see as tools of innovation policy, rather than saying here are patents, or here's regulatory exclusivity, or here's just a bunch of money to do this particular thing. Actually taking a really proactive view and saying where are ways in which particular government expertise and particular government functions can be leveraged to create infrastructure, to create tools, and to help overcome hurdles in the way of producing a type of information that we haven't traditionally focused on. So with that, I'll stop and take your questions.
I love this project, as you know. I think it's so interesting. But I want to ask you, I want to put up another hurdle for you. So implicit in your argument is that insurers need some sort of stick. They need some sort of maybe ability to decline to cover a drug if it turns out to be really toxic. But the hurdle is then formulary laws, right? So Medicaid has to cover basically all FDA-approved drugs. Medicare has to do that for a bunch of classes. Other classes of drugs, they have more choice. But it seems like you might be inclined to say something like we should get rid of the laws that require them to cover all the drugs. Then we get into problems like after the ACA, everyone was putting all the HIV drugs in the highest cost sharing tier. We think there are other pubs there. What do you want to do with formularies?
That is a really helpful point, and one we haven't engaged with in any detail, but I think you're exactly right. I think there are major, if what you want is cost-effectiveness research to make a difference, then it's hard to say, hey, once you have cost-effectiveness research, you can't apply it. When the PCORI was being created, in fact, that was part of its enabling act, was to say, hey, PCORI is not allowed to come up with a threshold of quality-adjusted life years per dollar, and if anybody comes up with something like that, Medicare can't use it. So obviously, if we would like this innovation to take impact and to create additional incentives for it, those kind of laws are going to be pretty problematic.
I think this project is totally fascinating, and probably I have more to share during some break. But so I was going to ask, you might have mentioned this, but I missed it. Are you going to explore the accountable care model in deeply in the paper?
So there's something. The answer, I think, is no. We're not going to explore it. The challenge with this is, healthcare and healthcare financing is an ungodly, wildly complicated, horrific mess. There are, and not only is it a horrific mess, but of tremendous importance to a junior scholar. It's wildly written about all over the place. And that's not where our comparative advantage lies. So I think in terms of kind of payment incentives and different ways of structuring payment and kind of ACOs and saying, hey, if we've got a patient-centered home, then they're going to be better about driving the incentives. I think that's not where our comparative advantage is. So when we say the incentives for insurers to do this are a little bit mixed up, we nod to that literature, but we're not going to delve deeply into it. But you're right, it's certainly important, semi-orthogonal direction.
Okay.
Is I like this a lot. It's a great project. Is this in Europe or in other places? Is this stack of papers or the data available? And if so, why? And if not, why not?
Frankly, I don't know yet. I think
The data in other countries, the data you're going after, right? The data that is aggregated about cost effectiveness data, the data, everything that you're aiming for. The big data trove that
Like
you want
single
to
payer
set
systems or something. Yeah.
Because I would imagine it is, and if so, do they, why? And if
right.
not,
So there are certainly some aggregated data sources. Some of the data access and privacy laws in Europe make some of these things a little bit harder to do. The other, I think some of the financial incentive issues here, the wild profit motives of the drug companies, the cost-cutting motives of the private insurers who are at least pseudo-competitive here, are much sharper in the US context than they tend to be in contexts where you've got a single-payer system and where you've got actual national caps on drug prices. So I think this dynamic we may see most sharply here, but you're certainly right that there are potentially troves of really interesting data which are already aggregated in some European systems.
So part of what you're talking about are the private insurers, not just Medicare and Medicaid. I'm just trying to think about, if you're thinking about this as a policy tool for some innovation, so what else could sort of be done there? Because when I sort of look at this and I think about the work by Mark Chernow and others, talk about value-based insurance design, there's a lot of all this formulary action already going on. And private insurers aren't doing this, maybe not 100%, maybe not across the board. I don't think they're doing it with dynamic incentive, these sort of innovation incentives in mind, they're doing more static incentives in mind. I could see this having incidental sort of innovations, spillovers at the moment. But I guess I'm just curious, like at least on the private insurance side of this, and thinking about this as a policy tool, what else? What else do you have in mind? In terms of alter regulations or I think there's a lot of it going on, but maybe we want more of it going on.
So we're out of time. I would love to chat with you more about this. The one thing that I'll say is, in terms of the public side of using this as a policy lever, you should all come to Rachel's talk because she's writing on exactly this, and it's really cool. So I recommend that. All right, thanks all, and very happy to take questions.